Very good afternoon and welcome to the panel discussion. So, thank you, Deepak sir, for chairing this session, and then looking forward for your valuable inputs here. And so we have our panelists, Dr. Rafi, Dr. Amit, Dr. Prakash, and Dr. Maqsood Alam. And Manas is not here for some emergency in his family. And so we'll quickly jump on to a good case of where PH and interstitial lung disease or PH is associated with interstitial lung disease. This is a patient with 69-year-old male and reformed smoker with 20-pack year history, shortness of breath on exertion for 6 months, dry cough for 4 months, evaluated in detail, blood work, CTD profile negative, no history of pigeon exposure, and viral serology is negative. And interestingly here, what is unusual in this patient is there is a family history of similar fibrotic interstitial lung disease in younger brother who is younger than, almost 10 years younger to him, underwent a transplant at UT Southwestern Medical Center, Dallas. And this really important in clinical scenario, the reason being, okay, he underwent a lot of recurrent hospitalizations after the transplant, the younger brother. So that's the reason this guy, though he is a fit candidate for transplant, he is not agreeing to get transplanted. So way back, four years back, we proposed him a cryolung biopsy, but he denied. And yes, as discussed, this is not an unusual patient in our clinical scenario, except for the familial propensity for fibrotic ILD. And after initial some suboptimal follow-ups in OPD, so there is a, in 2023 he presented with acute onset of grade 4 dyspnea. There was orthopnea and paroxysmal nocturnal. Yeah. So, orthopnea and paroxysmal nocturnal dyspnea, and no V's, creps present, no chest pain, no fever, oxygen saturations. Realized that he was room air few months back. Now he is requiring 6 liters per minute to maintain a normal saturation. Respiratory rate was, he was tachypneic, slightly tachycardic, higher on pressures, 160 by 90. ABG shows 7.41, PSCO2 is 38, PaO2 is 39.4, severe hypoxemia. So, sir, so how should we take this CaO2 levels and PaO2 levels here in as per this blood gas, sir? Deepak, sir. So,
sir, so there is a severe hypoxemia in this patient, and the patient already has got a paroxysmal nocturnal dyspnea, orthopnea. Edema is not there, but I would be expecting that this patient should be having some element of a heart failure also.
Yep.
And obviously patient is advanced pulmonary fibrosis now. I have advanced ILD.
I'll show you the CTs as well, sir, in short while.
Okay.
So what interestingly is that whatever it is, the ventilation is still happening. There is no ventilatory failure, and then it's a type 1 respiratory failure so far.
So what is the bicarb? Any idea what the bicarb?
No, sir, I'm sorry, I don't remember.
And do you think in a patient with the ILD, the patient should be hyperventilating a little bit, so it should wash out carbon dioxide?
Likely, sir. Likely. Probably his bicarb, maybe he may be a chronic retainer as well. I totally agree with you, sir.
In such patients, even normal PCO2
Sir.
may indicate some sort of hypoventilation.
true.
So we have to keep
Very much. He may be in failure. There may be already fatigue may be set
respiratory
in.
muscle fatigue. maybe.
Yes, sir. Yes, sir. I totally agree with you, sir. And why this? This is not just an ILD exacerbation, if you see. So I'll finish the case presentation and then we'll go for the panel discussion, probably another 4 minutes. So recurrent exacerbations are the most common trigger is, yes, probably infective triggers, progressive oxygen escalation, long-standing fibrotic disease, no wheeze, no fever, orthopnea, yes, that we should think of, cardiopulmonary involvement, preserved pH and PCO2, and not really in ventilatory failure. At this point of time, we should think of fibrosis alone cannot explain the entire physiology. And HRCTs will show you there's a slight increase in fibrotic burden, symptoms worsen disproportionately, and suggests this suggests a vascular limitation as well. Radiologically progress, but symptoms have progressed faster than the radiology. So this is the May 2023 scan, and June 24, and look at the mediastinal window, February 2025 and June 2025. So what is observed here is, yes, I'm sorry, I don't have a detailed 2D echo because all we at our center, there is no expert who is really providing me all the details of right heart status. So this is what we could get from the retrospectively from the data of the patient's file. But what I practice is the moment pulmonologists ask for a echo, they'll look for out of probably for the past 15 years hard work, okay, they invariably look for right heart more than left heart. That's what we could achieve in 1.5 decade of sincere hard work. So this is the parameters. RVSP was 30, now it is 50 in November 2025, and PA diameter as per the CT measurements is, so progressively it is getting increase. So what are we missing here? Yeah, multiple, as Deepak sir was commenting earlier in case, multiple admissions, it labeled as a exacerbations, ILD exacerbations, progressive hypoxemia, long-standing fibrotic NSIP, orthopnea and tachycardia, and likely right ventricular stress. This is where really the pulmonary hypertension in ILD patients hides. We'll come there. And in this case, there is a disproportionate dyspnea, which we should have addressed better. Recurrent admissions needs, that's an indication of something we are missing. Oxygen escalation is not benign. Acute worsening is not always because of ILD exacerbations. Right heart catheter should be strongly considered, and without dynamics we are guessing, and then guesswork always harms our patients. Coming to Sir Maksud sir. Sir, why PH ILD matters in clinical practice?
Because PH is common under-recognized fibrotic complication of fibrotic ILD, and naturally it change history of ILD.
So in clinical practice, this is often a neglected thing. If you see, most often in advanced ILDs, close to around 50% of patients, we come across pulmonary hypertension. Whereas if we look at the pulmonary transplant cohorts, almost 90% of them, they have pulmonary hypertension associated and frequently mislabeled as a ILD progression. This is what is concern. So unless we try to look into this actually, so we are missing this diagnosis. PH-ILD is not rare, not benign, and not optional to diagnose. PH-ILD is a hidden driver of decline and which is making the patient move towards mortality. So, coming to pathophysiology, so can you please let me know, in this patient, in a patient with ILD with pulmonary hypertension, what primarily drives the disease progression and outcomes? So, out of A, B, C, D, what is the most contributory factor? A, is it severity of hypoxemia? How many vote for it? B, extent of lung fibrosis and HRCT. C, degree of pulmonary vascular loss and RV pulmonary uncoupling. How many vote for it? Amitabh. And Amit sir, would you want to take this question? Yeah. So which one? You'll go for exacerbation. Right, sir?
Why one option?
All four.
Why one option?
No, that's why, sir. What primarily drives the disease? What is the most important factor in this?
So in ILD, if pulmonary hypertension is to be seen as a progression, it will be the lung disease itself. It has to be fibrosis then. Now fibrosis does what? Whether it causes exacerbations, whether it is causing hypoxemia, whether it is causing pulmonary vascular loss, it will all happen with fibrosis.
Yes, sir. So, primarily the degree of pulmonary vascular loss and an RV pulmonary uncoupling, that is what is the one thing which drives the disease progression and which makes the patient move towards more morbidity and more mortality.
But that's true for all kinds of.
It will be for everything actually.
Yeah.
This is all interlinked basically. If
True,
we
sir.
see.
I agree.
So there is no right answer, there is no wrong answer here. So that is, you are very clever.
But-
you have given a question for which there is nobody wrong and nobody right.
So, I ensure that all the audience are happy.
Yeah, that's what I'm saying.
No.
Master statesman.
You want to lead it to the final point after all the
Everything
conglomerate
will end
is
there.
going into the
End there.
RV and pulmonary uncoupling as the last.
True. That's there.
Okay.
So, interest of time, I will skip all this pathophysiology and all
Yeah.
those things.
Just-
And is PH-ILD
Epiphenomena.
is an epiphenomenon? What is your take, Rafi?
So what do you mean to ask is like is the PH is preliminary thing or
Is it
ILD?
preliminary thing or is it an associated thing?
Associated.
How do you see as a clinician?
Because PH has other causes as well. ILD is one of the causative agents. I think PH is epiphenomenon over ILD rather than ILD as a PH. But here, PH-ILD, I think you cannot take one as primary.
Right. Sir, anything else?
No, I am. I'm
There's
little.
also two answers.
Yes. So I think this is epiphenomena means that you are trying to ask us that when it happens, what is going to happen to the patient, right?
Right.
That's what you want.
Right.
So yes, if development of pH happens in ILD, everything goes down actually. That's what. So it's
So-
right what you said. Epiphenomenon.
So, actual cloning, that's what the actual turning point in the disease is early identification of pulmonary hypertension, and then how to manage that pulmonary hypertension is what we need to do. So, primarily in group 3, it's understanding the and then managing the underlying etiology makes very, very important. So, probably, okay, correcting the hypoxias, using the appropriate COPD management, probably adding a triple therapy, all those things matters. And when ILD becomes a cardiopulmonary disease, there will be definitely accelerated decline in patient condition, oxygen requirement will go up, right heart failure dominates the outcome. And Amit Bhai, okay. Quickly, when to suspect pulmonary hypertension in ILD patients? What are the various things that make you suspect PH?
When there is disproportionate dyspnea which is non-responding to usual treatment, and we may suspect ILD, and the FVC is preserved, and DLCO is out of proportion, and there is also sudden exercise intolerance, and which is not explained by the infection and other causes.
So, nicely put up. So, when there is a disproportionate dyspnea, we should think of underlying pulmonary hypertension, and particularly when the FVC is preserving. FVC probably it's staying at around 60%, 70% kind of thing, but DLCO is dipping down, as evidenced by even in our previous cases, our speakers have very clearly shown. If that divergence is occurring, FVC remaining static and then DLCO is dipping down, then we must suspect the underlying pulmonary hypertension, and DLCO by FVC ratio less than 0.6, which we should think of vascular phenotype, and then other clues: disproportionate exertional desaturation, rapid oxygen escalation, 6-minute walk distance less than 300 meters. These are all says that circulatory limitation is greater than ventilatory limitation. And Prakash Bhai, okay, when do you think, what are the, in clinical scenario, what are the various red flags that we should identify in our patients?
Sir, we have to go for this 2D echo. We have to primarily after doing all the clinical investigations, CT and this lung function test, we have to go for 2D echo. In 2D echo, we have to find out what are the right ventricle size, whether the size, right heart, the structural changes in the right heart and the left ventricles also. Then tricuspid regurgitation, we have to see the pressure, we have to see this.
So, as discussed by Dr. Tala earlier, so it is very, very important to look for all the various parameters. He has given close to around dozen parameters. So, all these things we should start looking in the echo, and we should also look at the CT clues. We often tend to ignore. So, when we raise a CT order for an ILD patient, it is very, very important for all of us to automatically, apart from the assessing the parenchyma, we should look into the mediastinum, and then we should look into the pulmonary artery diameter in comparison with the aorta, and this is very, very important. So, always try to compare with compare the RV size in relation with LV size. These are the very, very simple tricks, and then we should make it as a knee-jerk action. So, and then to identify, okay, whether associated pulmonary hypertension are we dealing or not.
So your patient has got a right pulmonary artery.
No boss, no boss. This is a representative image.
No,
okay.
That can be also reason for worsening. You
yes,
can
sir.
have actually
Yep,
MRI there.
yep. I agree with you. And late clinical signs, if you see, like as sir was mentioning earlier, so edema, raised JVP, presence of ascites or hepatomegaly, these are all late signs. Late signs should always make us think of we are dealing with a late disease, not a early disease. So, coming to the most important topic, that right heart catheterization. Yes, I am underutilizing it. We are all underutilizing it. I think the purpose of today the symposium is to increase the awareness of right heart catheterization, and then make sure that, the biggest challenge is there are people who can do right heart catheterization, but again how experienced they are, and then how whatever the values that they are going to give, can I rely on those values? These are the practical challenges which we are facing in day-to-day life.
Sir,
Rafi?
just a minute.
Yeah, please.
There was ascites in the what you have shown in the previous.
Yes,
So how you will define, sir, just ascites in this type of, which type of ascites, mild, moderate, severe, and how will correct the ascites in this form of disease?
According to me, if ascites has come, the train has left the station. You can't do anything.
Rafi, quickly.
I think this question is actually to Dr. Talha would be appropriate, but on the same token, I think actually to decide the treatment properly, I think RHC would play an important role, I think, to decide on it.
So, Tala?
Role of RHC in ILD PH is, very well put up. There is in the most recent WSPH guidelines, there is a very nice table that's put up which actually advises everyone not to just look at one parameter, everything in total. And this is nothing new as compared to what we've been talking since morning. Look at the clinical features, clinical trajectory. If symptoms are out of proportion to what you think, would necessarily happen with your ILD, look at the PFTs, look at the DLCO FVC ratio, and the biomarkers. Remember, in non-severe PH with ILD, there is no benefit in treating those patients with pulmonary vasodilators. So getting a good echocardiogram here is paramount for me to determine whether I need to do a right heart catheterization or not. In this case, if the echo shows severe pulmonary hypertension, without any further doubt, I would definitely push towards a right heart catheterization. If it's not showing severe pulmonary hypertension and showing a preserved right ventricular function, even though the right ventricle NRA is dilated, I may still say that let's just focus on the ILD aspects, and right heart cath may not change the treatment. Again, this is my practical way of dealing with it. If you look at the guidelines, it would be different. They would say that if you have significant PH with RV enlargement, they would still say that maybe in that case you may want to defer to doing a right heart cath early.
Especially
Dr. Tala, one important clinical thing. See, imagine the same patient has reached you already on dual vasodilators, and then is referred for right heart catheterization to you. How do you take it?
I would first stop the dual pulmonary.
How long to stop before do?
No. So ILD PH should never be treated with dual pulmonary vasodilators without a right heart catheterization. If they are on dual pulmonary vasodilators, I would probably not stop it. In that case, I would probably just do the right heart cath, see where we are, and then understand, because we need to know what to do in this current situation. So on current therapy, we will do the right heart catheterization, understand what their hemodynamics are, and then take the next therapeutic
and
decision.
probably stop it after the right
if
heart.
it's purely we think this is ILD PH, then definitely no role for the second ERA, probably a PDE5, and as we said, as per the increased trial, inhaled treprostinil.
Right.
And it works. I've seen it work wonderfully. Even before it got FDA approved for PH-ILD, I've been using it for at least last 5-6 years, and we've got good results.
So thank you. And it is gold standard, yes, confirms pre-capillary pulmonary hypertension, if at all, if it is any, defines severity and prevents the misclassification of the disease what we are handling.
I think it excludes pre-capillary pulmonary hypertension.
Yes, sir.
No, so ILD PH is also a pre-capillary pulmonary hypertension. ILD PH is pre-capillary pulmonary hypertension.
It excludes left heart disease.
Correct. It excludes left heart disease. ILD PH is pre-capillary pulmonary hypertension. Group 1 PH. Group 1 PH is basically hemodynamically pre-capillary PH in the absence of other pre-capillary PH, like your group 3 and group 4. That is what ILD.
So let's say you have a patient who has ILD, he has interstitial lung disease, and has pre-capillary pulmonary arterial hypertension. How do you decide that this PH is related to the ILD per se, or there is an element of pulmonary arterial hypertension which could be part of group A, let me put it that way.
Correct. So that is why I'm saying don't hang your hat on just the right heart catheterization. It's all of those features. It's your HRCT, it's your PFTs,
So I think you need to look at the holistic picture.
Correct,
Right heart
exactly.
catheterization will not give you that information.
It is important, but
But it cannot tell you that this
Exactly.
is a pure,
Exactly.
this pulmonary arterial hypertension is ILD related, or it is more than just ILD related.
Exactly. Yes, sir.
So that means there is not much role in doing it.
So that's
Typically,
that's
we
why.
pulmonologists
So if you have a
8-point rule.
very severe ILD and you have pulmonary arterial hypertension, I would be reluctant to do a right heart catheterization.
Sir,
Unless you're suspecting an incipient left heart disease.
so for ILD scenarios doing PH, I probably do it in very rare circumstances unless the patient is going in for a transplant, or second, if they have RV failure. Then I want to know very well what is happening, and then I can aggressively, treat it. But otherwise, I would not. So that's why even for this case, I said a good echo may be sufficient unless there is something unexpected on the end.
Anyway, very initially ILDs, when you wanted to look for pH, the 8-point rule of like pretty much you go through the scheme of what pulmonologists go through, typical HRCT, you have the biomarkers like say NT-proBNP, and then even the echo, as you said at the last, categorized into more mild, moderate, severe. Only severe I think probably would suggest for the actual for RSC.
Yeah,
category.
in the interest of time, okay, as of now, once the RV, we will wait till RV compromises and then do RHC. So, we have discussed this in the interest of time. Again, I just want to quickly, skip this slide. Pitfalls we have discussed, and then biomarkers. Dr. Deepak sir and Dr. Randeep sir has mentioned about role of NT-proBNP, and in severe PH-ILD, current definition, which is PVR greater than 5 Wood units. Okay, it matters most once we need to identify, because it says that the survival is really bad, and then PH-like behavior does exist when the in presence of severe pulmonary vascular resistance. And any comments?
So it's very important to understand this. It's not even the increased trial that showed inhaled treprostinil for ILD PH. This was the cutoff. They did not take all PH. Yeah, it was only severe PH with a PVR of more than 5. Only then they showed that there was a clinical benefit for the patient. So it's not all comers.
Thank you, Dr. Telha. And then we discussed about NT-proBNP use, and Prakash sir, okay, can you please, how do you differentiate PH-ILD versus PAH-ILD? So,
these are all the parameters, the extent of fibrosis and DLCO, severity of hypoxemia, HRCT, and hemodynamic severity. These are all the parameters. I think we have shown through this we can differentiate between the PH-ILD and PAH-ILD.
yeah, thank you, sir. So, it is very important for all of us to differentiate between PH-ILD, that is group 3, or whether we are dealing with group 1. These are the various parameters. Misclassifying would do more harm than doing correct to the patients. And quickly treatment, okay, non-pharmacological management, it is very important, particularly in group 3 ILDs, where the drug plays very limited role unless the disease is severe enough. We should ensure that we should manage these patients with long-term oxygen therapy, good amount of pulmonary rehabilitation is going on, judicious usage of diuretics, and then when is there any associated sleep disordered breathing? If it is there, we have to identify and then treat. And vaccination, infection prevention, all these things are very important. So acute decompensation in these patients, okay, can be because of acute RV failure, sudden rise in pulmonary vascular resistance, infections can tip off the balance, and arrhythmias and loss of preload and then excessive diuresis can also do more harm in these patients. And I am getting some signs from Dr. Indu that in next 2-3 minutes, please wrap it up. So, increased trial, what we need to understand from this inhaled treprostinil in pulmonary hypertension due to ILD is, it is a randomized control trial, and the outcomes, if you see, definitely there is a increase in 6-minute walk distance and then decrease in NT-proBNP levels. So, that is what is the take home we need to understand. And so, when we look at this, the change in baseline of 6-minute walk distance, so those when compared with placebo, there is definitely a statistically significant increase in 6-minute walk distance. And inhaled treprostinil is administered 4 times daily and is titrated to a maximum tolerated dose up to 72 microgram or 12 breaths per dose, and this is the first approved therapy for PH-ILD, and severe precapillary PH-ILD patients are the ones who are going to get benefited most. And then I look forward a quick comment from Dr. Tala on this paper.
So again, we do have the iloprost that we have available here is not the same as the inhaled treprostinil. What we do here is a little bit of an Indian jugaad. First of all, the inhaled treprostinil used there, that is delivered using a specific a neb machine or a device which is not available in India. So we simply use an ultrasonic neb machine with a fine mesh here in India to deliver this. The doses that they are using, 72 micrograms, is actually not very possible practically in our setup. What we generally give is about, we can go up to 30 to 40 micrograms per treatment cycle, and our patients, how much ever compliant they are, they cannot go beyond 5 to 6 times a day. Maximum they go up to is 4 to 5 times a day. Beyond that, they can't. The recommendation is to go up to this 72 micrograms and probably go up to 6 to 9 times a day, which is not possible. People can't be awake those many hours. So, yeah.
VQ scans be done for when you are doing this kind of treatment?
Can VQ scans be done?
Like follow-up treatment?
Yes, if there is a change, in the clinical trajectory, you have hypoxia and you're suspecting PE, yes, absolutely, VQ scan can be done.
So in terms of
clarity of only ventilation, but not.
So I think the issue, what you're trying to say is that since it improves ventilation, it improves the VQ matching.
VQ matching for patients on inhaled treprostinil, is that what he's asking?
Something being incorporated.
So I think what you look at is a 6-minute walk distance. Yeah. That improves.
That
VQ scan would be a more, but it can be done. I'm not sure whether it's been done. But it's not something which will be very practical.
I'm not sure.
And then the easy markers like NT-proBNP and 6-minute walk distance can be a surrogate marker.
If it is not improving, probably you would want to subject a patient, in spite of this treatment, is something on the pipeline to think about, to follow up as a VQ scan can be done or something.
That's a more cumbersome, Dr.
I know.
So I think
easy way, as Dr. Randeep sir said very clearly, 6-minute can be done.
I know.
And then of course NT-proBNP can be followed.
So the question I would have is, when do you decide that the patient is a responder as compared to not responding? Will you give the inhaled drugs and say wait for about 4 weeks, or?
So you saw those curves diverging out very early.
Very early.
Yeah, so they do. If the patients are feeling better, within a month they should start seeing a difference.
Correct. So usually the divergence starts early, you would say about 4 weeks.
Yes.
4 weeks.
So 4 weeks.
Within a month you should start seeing a difference,
And what we need to understand is, do not attempt ambrisentan or riociguat on presence of PH-ILD. Okay, it is going to cause bad outcomes. And inhaled nitric oxide, again not robust data what we have, and various studies thus reveal like PD5 inhibitors have. Indu, are you doing it?
Very, very impatient now.
Quickly, last couple of slides.
I think they've decided to cut you off.
So overall pathway, if you look, so if there is a suspicion of ILD PH, so is there any underlying exacerbation of ILD? If yes, treat exacerbation. If there is no, obtain the screening test for pulmonary hypertension like transthoracic echo, BNP levels, VQ scan, PFT, CT chest imaging, 6-minute walk distance, and high suspicion of ILD PH, and consider referral to PH expert center. If there is no, then continue management of underlying ILD, consider serial monitoring for development of pulmonary hypertension with the recommended test, and at PH center, pursue diagnostic right heart catheterization. Are there risk factors for left heart disease? We have to look, and then if there is a left heart disease, then we have to ensure that manage left heart disease appropriately, and if there is no left heart disease, then definitely there may be a chance of precapillary pulmonary hypertension. And overall, this is my last slide. So management of pulmonary hypertension, the approach is identify patients with ILD at risk for pulmonary hypertension, screening and diagnostic testing, determine the underlying etiology, and then classify according to WHO grouping, and treat the underlying condition. That is what matters most in group 3 is supplemental oxygen, smoking cessation, underlying identify the obstructive sleep apnea and sleep disordered breathings, correct it, pulmonary rehabilitation, optimize the fluids, routine vaccination, and evaluate the patient for candidacy for lung transplantation. And PH ILD directed therapy in mild PH ILDs, monitor closely with functional tests, and in severe PH ILD, so single or combination vasodilator therapy, okay, if it is the PVR is more than 5 Woods unit, and enrollment in clinical trial, avoid at any cost ambrisentan and riociguat. Thank you so much. Thank you, my dear panelists.